we will proceed further, and I would like to invite Dr. Nayan Timbadiya. Thank you, sir, for joining us today. I would like to give a brief introduction. Dr. Nayan has done his DNB urology. He's a urologist, andrologist, and a transplant surgeon. He has done his DNB urology from Bangalore and MBBS and MS surgery from MP Shah Medical College, Jamnagar. Sir is a consultant urologist and he has delivered superior patient care and treatment by gathering information and reviewing a patient history and addressing the patient's queries. His core competencies are men's sexual health and management and male infertility problems and its management. Sir has delivered various presentations and publications. His main presentation is Role of Trust to Rule Out Prostatic Abscess in Diabetic Patients with Recurrent Urinary Tract Infections, Complications of Urethra Abscess Sheath, the role of sepsis bundle in urosepsis patients admitted in ICU, and cadaver urethroplasty, an ideal training tool in Eurofair 2021. His publications are Cadaver Urethroplasty and Ideal Training Tools and Novel Use of Forearm Perforations in Vascular Abscess. Sir, I would like to start. I would like you to start your presentation. Thank you, sir.
Thank you very much. I would like to thank BOGS for giving this opportunity. My talk will be on the management part of Oligo, Asthenozoospermia and Azoospermia. I will focus mainly on the surgical part because I am a surgeon as a urologist. But other than the surgical part, there are many things that we all of should know about the medical part. So to be start with, as we all know, the incidence of these patients are rising more and more nowadays because of the modern society and because of junk food, smoking, alcohol, drugs, etc. We have the lots of idiopathic oligospermic patients and many primary testicular failures because of these risk factors. So what I feel is education is must for our society to prevent or to reduce the burden on the society as far as IVF and IUI is concerned. So if we educate our people about the early detection, at least early detection, you forget about the preventive part. If we diagnose early, then we have many patients, we see the good count around 10, 12 millions, and after 6 months they will just take Ayurvedic medicine, this, that and all, and after a few months they will come with the 5 million count. So if we detect the early, then we can offer the low cost treatment, and that is the advantage of early detection. So education is the most important part, that is what I feel, rather than other medical treatment like antioxidant and etc. So these definitions everyone knows, sir has explained. For azoospermia, we need 2 consecutive sample 2 weeks apart, and as per new guidelines nowadays, no need to wait for 3 days abstinence. 24 is the good time to consider to define the any patient like oligo or azoospermia. So 24 hour, if any patient having 1 day abstinence, that is good enough to define. These are the risk factors. We know we have the pituitary problems, pre-testicular problems, testicular problems, and obstructive part. Most of the patient we have is testicular problems like idiopathic oligospermia and azoospermia. And as I told, that is all because of the lifestyle modifications and other drugs. So we'll not go into the theory, but if we see the chart, most of the patients having the either idiopathic problems or genetic problems. So if you see the percentage, mostly around 70% of the patient will have the genetic or idiopathic oligospermia or azoospermia. So, and we don't have specific risk factors, so we don't have specific targeted therapy for that 70% of the patient. And that is why we are not able to achieve the result by medical therapy or surgical part, because this kind of patient will need either today or tomorrow IUI or IVF, and that is why IVF numbers are rising because of this problem. On evaluation part, history is important for all of us as a medical person. Examination, whenever examination, I would like to highlight that I have seen many patients evaluated elsewhere, whether a gynecologist or IVF center. Many patients, they have just reported examination normal, and when we see the proper local examination, there is a absent VAS, either unilateral or bilateral. So what I feel that at least one of the staff should train how to examine the VAS for all the patient of yours, because many patients we are missing the in examination only we are missing the VAS presence or absence. The management part is totally different. If you have labeled that everything is normal on examination, then we are giving medical therapies and other stuff, MRI, etc., ultrasound. If VAS is absent, then there is no further investigation required. You can directly go for sperm retrieval procedures. So we can cut down the cost. Definitely we can cut down the cost. So examination is very important for severe oligo and azoospermia. So the VAS examination for the patient, one staff has to be trained, and other examination like syndromic problems, you can examine the male breast, the pubic hair, and so many things to rule out the pituitary problems. So that is the important thing. Lab investigation, that is what all of you are doing, that is a regular one. Diabetes, HbA1c and TSH is the extra thing that we can do, and that is directly related with, as I told, because of obesity and metabolic issues, it will directly affect the sperm production. Karyotyping and genetics. Karyotyping, as I told, any idiopathic patients, when we suspect the genetic problem or any obstruction, like as I told, absent VAS, we have the CFTR gene mutation. So that is what we do in the later part after basic evaluation. Imaging to rule out the obstruction, ultrasound, truss ultrasound, rather the rectal ultrasound, and then sometime we do MRI also if any doubt in the truss. Biopsy we offer when any individual having the normal examination, normal basic test, hormonal profile, normal ultrasound, normal MRI, everything is normal. Testis volume is good, VAS is present, then only we advise biopsy. We cannot advise biopsy for all the patient. Okay, so that is important. And vasography is difficult to perform. As a urologist, we have to take the patient into the OT. We have to open the VAS, and then we do the vasography to check the VAS obstruction. But these are the rare cases. Most of the time we have the obstruction at the prostatic level that we can easily pick up by truss and MRI. This is the flow chart how to evaluate the oligospermia patient. This chart you will not get in the any textbook. This is made by me as on the practical basis. If any patient having oligo or severe oligo or asthenozoospermia, first you do the examination, as I told, testis volume, epididymis, turgid or small, VAS present or absent, and veins, varicose. You have to check the varicose veins. In examination, you will find only two things. Either everything is normal, or there is a small testis or varicocele, with or without varicocele. If everything is normal, then you proceed for hormonal evaluation like FSH, LH, testosterone, etc. If this testis is small with varicocele, then you have the thought that there is some testicular issues, whether because of the idiopathic things or because of the varicocele. So after examination, you do the basic test, and if you see the results, there are 4 different possibilities. The first is high testosterone and LH. What is the meaning of that? When there is a high testosterone in the body, that is the problem with the receptors, like testosterone receptors. So that is called androgen insensitivity. So this kind of patient, definitely no medicine will work, and then you have to proceed with the sperm retrieval and IUI. The second possibility is normal. You will get examination normal and hormonal profile normal. These are the idiopathic obstructions, like some vase obstruction. Outside everything is fine, truss is normal, no obstruction at the prostatic level, no obstruction at the epididymis or vase. But vase is lengthy, 25-30 centimeter. So any obstruction in this vase, everything will be normal, but still there is a oligospermia. That is also possible. Third is low FSH and low testosterone. So that is primary hypogonadism. All of you know this term. And then we have to do MRI to check the pituitary and then proceed further. And the most common scenario in our practice is high FSH with oligospermia with high FSH. So then that is primary testicular failure, and then we have to do the scrotum ultrasound to look for the size. As I told, you can check the size, you can check the varicose veins, etc. And sometimes we do the genetic testing to check the idiopathic genetic primary testicular failure. So that is how we evaluate step by step. Sometime I see like examination is okay, but partial hormonal evaluation. Sometime hormone is full, but examination is not proper. So there is plus and minus. But if you go order to order, then you can evaluate properly. Azoospermia, same way, examination is important. As I told, if vase is only absent, sometime what will happen, they will check the vase on the right side, it's present, that means okay. But there are many cases of unilateral vase absent. So you have to check on the left side also. So bilateral examination is must. And if vase is absent, then don't do any investigation, no ultrasound, MRI, hormone, nothing. Only you have to focus on you can do the CFTR gene mutation for couple, male and female, because female is also important when there is a CFTR mutation. So, and after that you can directly go for the sperm retrieval. Ideal sperm retrieval for this, any obstruction rather, is the epididymal sperm retrieval. So you go for epididymal sperm. If not possible, then you proceed for other testicular aspiration or open biopsy. If everything is present, vase is good, testis is good, epididymis is good, then you do the FSH and ultrasound scrotum. Ultrasound scrotum to check the volume of testis and FSH. If FSH is high and volume will be less than 4.6 ml, that is primary failure, primary testicular failure with azoospermia. Then only thing that we can give the result by micro-TSA. Now micro-TSA is practically almost very few centers in India that is possible, because as an andrologist, that is around 20-25 lakh scope I have to purchase, and for that I have to carry the your lab, sperm, the technician, etc. And for you IVF centers, this cost effectiveness is the problem. So as a combined, where the institutes where the andrology practice and IVF practice both are there, then only you can do micro-TSA. Otherwise, many, I have seen many neurosurgeons are doing with this our glass, that is some 2 or 5 x. That is not correct micro-TSA. Rather you do open biopsy, take it the good chunk and give it to the technician. That is good, rather than doing this just because of we are just labeling the micro-TSA. That is not micro-TSA. So if you want to do proper micro-TSA, we have to purchase the scope, and then you take the one tubule, dilated tubule, take out and then give it to the lab. So that is actual micro-TSA, and little difficult to establish this, but that is the ideal thing for azoospermia with primary testicular failure. The second, if FSH is normal and ultrasound scrotum is normal, testis volume is good, then you can do two investigation. One is truss and the second is urine analysis. Truss to rule out the obstruction at the prostatic level. If any obstruction, we can just put the scope, open the ED, we call TURED, transurethral resection of ejaculatory duct. Okay, so that is one small endoscopic surgery, and then we have good results because we have to just open the orifice. If urine analysis showing some sperm, that is called retrograde ejaculation, and then you can alkalize the urine and collect, and you can use for IUI or IVF, whatever. So that is how we can follow. The, if your truss is also normal, urine analysis not showing sperm, and everything is normal, then only we do biopsy. As I told earlier, biopsy is the indication is only when everything is normal. Volume is good, hormone is good, truss you have done, there is no obstruction, then only we do biopsy to check whether there is a sperm generation, regeneration or production is there or not. And sometimes we do vasography. That is also difficult to perform, and very rarely we do. So these are the two charts to evaluate, and the management part, very minimal things we can do or we can offer to the patient. If you see the medical therapy, hormone therapy, we can use in two kind of patients. The one is patient with primary hypogonadism. As I told, any pituitary problem, you can give the hormonal therapy, and then you can induce the production of the sperm in the testis. That is one indication. The second indication, patient having oligospermia, and the FSH is normal but at the lower side. Whatever range, your range, uh, it's showing normal but at the lower side. Then you can advise the hormone treatment to increase the production. Like for example, 5 million, you will get some 7, 8, 10 million, and then you can try the IUI rather than IVF. So that is what we can change the treatment part. So generally what I use is the HCG 5000 3 times in a week along with the recombinant FSH. FSH is also 75 international unit twice in a week, and 2 to 3 months we have to give as a combined therapy, and the over practical result is around 30%. I mean, if I have given to the 10 patient, 3 patient will have some raise in the sperm, but 70% no use. So that is again the result wise not good for the patient. But anyway, everyone knows patients are just roaming around. They want to do whatever Ayurvedic, homeopathic, this, that. So we will try, and then at least 3 patients out of 10 we can have some at least IUI, not IVF. Sorry. The second is entry androgens. That is your subject. We are giving clomiphene, but practically I feel for male patients there is no use. We are just giving for 2 months, 3 months. Very hardly we see the results, and that is also mild results. Like few millions will increase. Not practically not good results with the clomiphene. The third is very important thing. Everyone is using antioxidants, and many companies are there for antioxidants. They have just combined everything, like coenzyme Q, carnitine, vitamin this, that, E, D, whatever vitamins are there, they are just combined. But what recently I went to Bangalore. My college is from Bangalore, so I went to Bangalore, and there are many centers. They have one meeting few years back, and they have decided that why we are not getting result with antioxidants like whatever available. So then they have started one study, and then one company they have hired, and then they have suggested that you do one thing for counts and morphology, you target whatever, because if you see the theory part, uh, uh, astaxanthin and so many other vitamin D that are only for counts, not for motility. So they have what suggested that you focus you combine the medicine only which target counts. There, I have the details I will share in the group. So they have made one drug that is called Morph, tablet Morph, that is only made for the count, to increase the count. And the other part, there is one more medicine that is called tablet Motil. They have combined the drugs which are useful for motility, like coenzyme Q. So they are giving these two separate drugs to the individual, and then what they are saying, I have no personal experience, but they are saying that results are good. So I have recently started in last 6 months, we are giving these two separate drugs, not available at our area, but I will just give the number to the individual patient, and then they will just courier it. So result I have to check, but that is what they are saying. So I feel the scientific base, if we give these two separate drugs with good concentration, it will improve the sperm counts. So, So that is what I want to highlight in antioxidant. Otherwise, many things are there, and usually we'll give for 3 months and 6 months. It will go on, but there is no result. That is what the problem with the antioxidant. This is surgical part, obstructive. Any obstruction we find in this evaluation, we'll do TURED as I told. Varicocele correction, very important for you people. If grade 1 or 2 varicocele in ultrasound, you will refer to endocrinologist, you do varicocele surgery, there will be no result. There will be no result. So, and you know this nowadays, any small surgery cost is around 40-50,000. Any small surgery, we do prostate small surgery, the average cost is 40-50. Now, in future you will do some IUI or IVF, that is also cost effective. Why we do unnecessary varicocele surgery when there is no result? We know there will be no result in grade 1 and 2. So please don't focus on ultrasound reporting. If you feel there is a clinically high grade varicocele, you refer to us, we will examine. If there is a grade 3, 4, we will check with the ultrasound whether there is a reflux. There are many criteria like more than 3 mm, 4 mm, then only we do surgery. So all patients reported in the ultrasound don't need the varicocele correction, and then if you do also, there will be no result. Okay, so that is important thing as far as varicocele correction is concerned. And when we do varicocele correction in 3 and 4, there also the result is around like 30, 40, 50, maximum 50, practically 30%. Okay, so that is also again low. So we cannot guarantee to you do this and then there will be a good results. Non-obstructive part, all of you are doing this epididymal sperm, but what I want to highlight is first try epididymal sperm whenever possible. Okay, if not possible, then you go for testis aspiration and then go for open biopsy. Testis aspiration, the reti testis is good for sperm, so you whenever you put the needle, focus medially and superiorly. Don't not anywhere you cannot puncture and do the testicular aspiration. So when you puncture at the middle part, but you direct in the upper pole and the medial part. That is important. And for suction, don't use 10 cc or 20 cc syringe. You have to give the good suction. So at least you have to use the 50 cc syringe. Okay, so that is 2 points. That is what I have observed in this last 3 years. That is what I am telling. Otherwise, again, everyone knows when we go for IVF, results are very poor. We cannot give the sperm, and then we have, as a urologist, we have 2-3 surgeries. After most of the time, this kind of surgery at the morning, if we have not given the sperm, when technician says there is no sperm, we feel very guilty. I don't know why, but results are very poor with all this. But because not too much cost of this percutaneous procedures, we can offer the patient, and if we find that is good for the patient and for us. This is very important slide as a urologist, endocrinologist, and that is what I want to highlight it. I want to highlight weight control is very important. Obesity, as I told, modern society. If we all focus on the preventive part, many patients we can have the good fertility. Okay, we can reduce the IVF numbers, we can reduce the IUI numbers. Once there is a oligospermia, there is no proper, we have seen in the previous slide, there is no good results with medical therapy, surgical therapy, whatever. If you focus on prevention, then only good for the our society or patient, whatever you want to say. So smoking, alcohol, healthy diet, exercise, we know everything. We know everything, but we are not following. As a medic also, we are not following. Education is must. At least your individual center should have the 1 or 2 lectures in a month for education. If you educate for 50 or 100 people in a month, that is also good enough to have the good fertility in the future. And early detection, as I told, many patients having good number at present and then reducing the number after few months. So early detection is important. Recent advances, plasma cell therapy is going on, research is going on. Result will be maybe 1 or 2 years, it will come. And then if we are giving the good results, then we can simply, it's a percutaneous procedure. We can inject the plasma. Plasma is also individual. We can just filter the blood and we have the plasma. So that will be the good if we have the good results in the research. So this is highlight. Prevention is the only treatment. Antioxidant having the limited role. Success rate of sperm retrieval is also very low. Reconstruction surgeries are very difficult and complex for us, and with low success rate. Varicose surgery correction has good result only with the high grade varicocele, and hormonal treatment may improve fertility in central causes of oligo and some type of testicular failure. That is the take home message. If any questions, I am ready to answer. I have personally not used, sir. Yes,
surgical sperm retrieval rate may be 60-70%. So what we are doing, start the stimulation and tell the patient what are the 60%, 70% chance. What we are doing, because after if you do testicular sperm and few sperm is there, the cryosperm, if you use in a see, the result is less, very less. To avoid this, what we have to do, fresh stimulation, fresh egg, and same time do TESA sperm. If you are not find the TESA sperm, go for the micro test and find out whatever give the maximum chance. We have team, 4-5 people are working for 5 hours, and each and every testicular tubules are seeing under microscope, pinkish and whitened testicular we find out, and give the fresh egg, fresh sperm, make the embryo maximum and transfer it, then chances will be high. Counsel the patient the 60% or 70% chance of surgical sperm retrieval. What about if you are not found the sperm? Then counsel before the starting of the stimulation, take the consent for the donor sperm if they are ready. Those who are not ready for the donor sperm, we will do egg cryopreservation if we not find the sperm. That is the most practical way to do.
So I have seen the two different practice among the IVF centers. One is what you have explained, that you go at a time, whatever will be the result. Other is we do trial TESA first in the one testis. If everything is good, then you induce your cycle, whatever, and then we have the option of second testis also in the same time. But it's a time consuming, cost effectiveness. That is practical issue. I mean, whatever पैसे वाला patient है तो they will agree with trial TESA. If economical concern, then you have to go at a time. So it's a practical approach to the individual centers. That is okay. But as I sir told, better if we have the one go. That is what I feel.
So what we have to select the patient about the FHH level, testicular weight, and estrogen level and testosterone. So by and large, we not do in each and every case of to do but testosterone level and estrogen. So those who are obese, having FHH normal, in that case you can give anastrozole. That is a molecule like aromatase inhibitor. 1 milligram for 2 to 3 months. Those who are below 60 and having FHS normal, you can try with the clomiphene citrate, low dose, 25 milligram. For 25 days, rest for 5 days, again 25 days, again 5 days rest, again 25 days. So in that manner, low dose of clomiphene citrate, you can try for the 3 months. Those who have normal FHS and weight is less than 60 for 3 months.
Anyway, as a andrologist, all this therapy is already given by you. So my job is to, other than, yeah, I know. That is why I have highlighted how to do it. That is why, because say in as a my say yeah. So that's why I highlighted that you do like this so that we have good results because
As per law is concerned, previously in the law only MCH, urology, yeah, andrology, urology, MCH, they can do, but now they included general surgeon because in district place everywhere MCH is not available. To make more availability, they make general surgeon having special interest in male infertility and taken training about testicular sperm retrieval and having certificate of 15 sperm retrieval certificate. That is, they can do surgeon, general surgeon, but with certificate. Cannot do. No, no. General, MC, any, even senior IVF patient, by law, they cannot.
anyway, sir, this modification is good because if you see the urologist, no one is actually interested in this because small procedure, yeah, income is very minimal, and and
Very true. Very true. Very few having interest.
there are many stone, prostate, this, that, so many things are in urology. So they are giving, patients are giving good money in that area. I am as a urologist, my focus is on sex education. I focus only on sex education. My next Sunday, my opening as a Heroes Hospital in Rajkot. All of you are invited. But even as a sex educator, also I don't do any urology surgery still. There is a no time for, I have to go to from my hospital to search IVF center and then there is will be some plus minus and then I have to come back to the hospital. So practically that is not possible. So you have to modify your law to the, so that gynecologist can do these procedures so that
Now they we may with the MCH and DNB people, MD Gynec plus having MCH and DNB in ART, IVF, taken training, they will allow.
that is good.
When you take the first sample, the sperm count is very low. But after 1 or 2 hours, when you take the second sample, you can have a good number of the sperm.
That is, sir, physiological storage things. That is just a matter of the storage in the epidermis and the vas. So that is why we confirm by doing multiple samples. We cannot rely on single sample. That is normal physiological thing.
Normal physiology, but by practically we have done ICSI and we have presented study also, and second sample having good morphological normal because this is a fresh sperm.
Yeah.
The storage sperm having lots of
Yeah,
DNA
that's why, sir.
fragmentation.
The second sperm will be from collection will be from epididymis. One is from the vas, and that it contains very minimal count and fluids. That is the reason.
Thank you. Thank you very
Thank
much.
you.
Thank you, Dr. Nayan.